words.
So welcome. And for the first meeting at the Trauma Center, Jackson Memorial Hospital, on our trauma fellows, please start the case. Thank you.
Thank you, Dr. Martis. And Dr. Carter?
Yes.
So let me introduce you. Today we have a presentation from Dr. Nicholas Carter. Dr. Nicholas is a fellow trauma surgeon from Ryder Trauma Center, Miami University. Thank you, Dr. Martis. Thank you, Dr. Carter, for accepting our invitation. Are you ready to start?
Yes.
Your
All
turn.
right. Good morning, everybody. Thank you for this opportunity to present the International Trauma Telegram rounds. I'll be presenting a case of penetrating thoracic trauma we saw recently here at Ryder. Dr. Martos was the trauma faculty for this case. And before I start, I want to acknowledge that here at Jackson, we've been celebrating this past year the arrival of a fantastic group of lung transplant surgeons. Fortunately, our patient did not require a lung transplant, but he certainly did benefit from the consultation of this group of very talented thoracic surgeons. I want to start by thanking Dr. Mauricio Pipkin as well as Dr. Machuca and their fellow Daniel Butrago for the incredible assistance that they provided in managing this complex patient. The patient was a 39-year-old male who arrived with multiple gunshot wounds. He arrived as part of a mass casualty event with reports of up to 10 people shot in a single incident, with 4 operative gunshot wound patients arriving simultaneously to our trauma resus area. At the time, there was already a critically ill trauma patient in the operating room, and an additional unrelated gunshot wound patient arrived soon after. The logistics of managing this event are to be presented in a subsequent Pan American Trauma Conference. Today's presentation will focus on this particular patient. On primary survey, his airway was patent. He was speaking in short sentences. He was tachypnic with a respiratory rate around 30, maintaining his oxygen saturation at 96% on room air. He had diminished breath sounds on the left. He was tachycardic with rates to the 140s, blood pressures of 130s over 90s. A left chest tube was immediately placed for suspected pneumothorax. There was a large rush of air and approximately 50 milliliters of blood returned, and his heart rates improved to the low 100s. He had a GCS of 15. He was following commands with all 4 extremities. And on ballistic survey, he had this complex wound to the left thoracoabdominal area with at least 2 gunshot injuries within that wound. There was also a penetrating injury to the right buttock and what seemed like a superficial through and through injury to the right arm. He was noted to have diffuse peritonitis on abdominal exam. His pericardial ultrasound window was negative for pericardial effusion, and the patient was immediately intubated with grade 1 view, single attempt 8.0 ET tube, and brought directly to the operating room for laparotomy. His base deficit upon leaving the resuscitation area was -3, and his hematocrit was 38. This is the chest x-ray that was shot just before leaving the trauma bay for the OR. Here you see the ET tube, perhaps a little high, left chest tube in good position. And then he has ballistic fragments throughout the left lower lung field, as well as the left upper quadrant of the abdomen. And there's an additional ballistic fragment in the right upper lung, and it's rather subtle, but along the outline of the left main stem bronchus. Because of the context of this patient's arrival, as well as diffuse peritonitis on exam, he was brought directly to the operating room for additional management. In the operating room, on laparotomy, the patient was found to have active bleeding from the spleen, a through and through penetrating injury there, and a splenectomy was performed. He had penetrating gastric injuries, which were resected as one as part of a stapled wedge resection. And he also was found to have 2 areas of diaphragm injury that were both repaired primarily. His EBL was estimated at 50 milliliters. He received 2 liters of crystalloid and 1 unit of packed red blood cells. He had 300 cc's of non-bloody urine. And in the postoperative period, he was brought directly to the CT scanner. Here's the CT scan. And I'm going to show this first just to establish trajectory. Here you have the ballistic in the right upper lung field, and you can see a trajectory that appears to be through the posterior mediastinum. And we spent a lot of time picking through this this imaging, and so I'm going to show a couple of slices that we looked at closely with radiology. The first, in this slice, there's a bullet fragment that is just adjacent to or questionably within the esophagus. There's also a streak artifact in the area, and it's difficult to assess if this fragment is within or just next to the esophagus. Just a couple slices down, we have it's an area that's suspicious for a sub-millimeter or sub-centimeter defect along the anterolateral wall of the esophagus with a focus of gas extraluminal, concerning for an esophageal injury. In lung windows, you can see that there's also a possible defect in the wall of the left mainstem bronchus. So at this point, the patient is recovering from his laparotomy. He's up in the intensive care unit, and this is our first branch point for decision making. Does this warrant operative intervention at this point, or should we pursue additional workup or procedures?
Thank you, Dr. Carter. Dr. Kassim, would you like to make any comment?
Good morning.
Good
So
morning.
this is can you hear me?
Yes, I can.
Good morning. So this indeed is a complex problem. Question for you. When you saw something on a bullet fragment on the right side of the chest, and then a lot of fragments on the left side of the chest, did it raise the possibility that this could be transmediastinal injury to you initially, or this was something latent?
That's a very good question. And so I've spoken in detail with the team that originally assessed and operated on this patient. And my understanding is that they did appreciate, I'll go back to that original x-ray. The faculty in the case did appreciate this fragment and the possibility of a transmediastinal gunshot. In the circumstance of managing multiple operative traumas at the same time, the choice was made to not delay in bringing the patient to the operating room, but to do the laparotomy for what seemed like an obviously operative constellation of injuries within the abdomen, and then to pursue additional post-operative workup, which is why he went for the post-operative CT scan.
Very good. I think I would have done the same thing. I would have taken care of, stop the bleed. That's what's happening to this patient immediately. Obviously, he has an injury to the spleen and possible injury to the other viscous in that area. And I would have suspected the diaphragmatic injury as well, and I would have done that first. But before I take him to the intensive care for further resuscitation, I may have taken the opportunity to have a look in the esophagus with an endoscope and possibly even a bronchoscope at that time. And so I can kind of gauge what I'm going to be doing next. And that's what I would have done. But I think it is quite acceptable to take him to further resuscitation and delay any further resuscitation to come back some other time, as long as you do plan to come back. I think one should not play ostrich, and that is my point. So what I would do, what I would have done would be, what I would do now that you know that you have a possibility of injury to the esophagus and also possibly injury to the bronchus, I think the esophagus can be treated nowadays, with the endoscopy and placing a stent, if it is not complete luminal destruction of the esophagus, if it is just a tiny bit of a hole there or defect there, you can place some type of a stent in there, and there are stents available for that purpose, and then and see what is going to happen to the bronchus for the time being, and that's what I would do. I would like to hear what other people would do in a complex case like this. Thank you.
Thank you, Dr. Kassim. Dr. Frisbee, do you have any comments?
Yeah, I think I think Kassim's got it. You always want to do the thing first that's going to kill the patient first. So the abdomen is, every one of us knows the abdomen's where you're going to die from, not the chest. And I think his approach is appropriate. I used to give them a little bit of a thin barium and not worry so much as long as your chest tube's in place, and do it that way. But you can do that after you've resuscitated him in the ICU. So I think that's about right. That's what I would do.
Thank you, Dr. Frisbee. Dr. Collet, do you have any comments?
Yes, I have some comments. I agree with all comments because first straight the hemorrhage, and the things that can be life-threatening injuries. So I think you can stop blending and then go to the other injuries. When you see the transmediastinal wound, you can go to investigation during the surgery, and can go to an endoscopy and bronchoscopy. I think the most important thing is the drainage of the chest. If there is a bronchial fistula, a pleurobronchial fistula or not. If you don't have pleurobronchial fistula, the injuries of the bronchus contained by the mediastinum can be wait for treat. But the esophagus injuries, sometimes you have to treat. You can use endoscopy if you have. You can treat by endoscopy. You can put a stent or sometimes you can put some needles, some clips can close the esophagus injuries. Can be done in some people who have problems during the endoscopy, have esophagus injuries. And then if you can possible to close it, that's very good situation. So if you're not, you can go to treat surgery. So I think there is a great problem to treat each surgery, because when you open the mediastinum, you have a tamponate bronchial fistula. You can open this fistula and may be very difficult to treat all injuries, airways and esophagus injuries in this position. So I think I can try initially to go to endoscopy and try to treat and observe the bronchioles along the days. That's it.
Thank you, Dr. Collet. Dr. Menegoso, do you have any comments?
Yeah, I agree with all of them. I think you have maybe the possibility of doing endoscopic study of the esophagus and also using the bronchoscopy. But I think that maybe you could add both. You could just use the endoscopy and also do a contrast study of the esophagus, so you can enhance your sensitivity especially for small injuries. But that's the only comment that I would have to addition.
Thank you, Dr. Menegoso. Dr. Carter, your turn.
Okay, thank you, panelists. And we took a similar approach to what you're describing. First here is the esophagoscopy performed. This was actually up in the intensive care unit. And I'm going to go to minute 1 here.
So that's where are you?
Oh, that's a defect.
Yeah.
That's it. That's it. Okay. Show again. What level are you? I'm at 30 centimeters from the T.
So there you have, we have at least one area of esophageal injury occurring about 30 centimeters from the incisors. And then our bronchoscopy, and actually the honest truth is it took us several bronchoscopies to identify this. This was the one that was positive after several negative bronchoscopies.
That's more evident now.
Yeah. What the signal?
Very proximal. But the carina is there at this point.
There, so there's the carina, and actually it's not captured in the video, but there's a pretty subtle area of intermittent basically bubbling from the membranous wall of the left main stem bronchus that was seen, but not captured in that video in its active phase. But that's what convinced us that we had visualized an injury. And so we found ourselves at this point with, we thought, at least one and perhaps two separate injuries that were likely to require intervention, and we had to decide on our approach.
Thank you, Dr. Carter. Dr. Frisbee, would you like to make any comment?
Not right now, but the optimal approach obviously is what, the easiest one you can do. You can put a shunt across there, but you're going to have to do something, address that bronchial injury for sure. At this point, I'd like to hold on to what I'm thinking. Let somebody else come forward.
Thank you, Dr. Frisbee. Dr. Cassin, any comment?
Now that Dr. Frisbee has passed the bug, I will try to see what I can do here. So I think, there was a case like this in Portland several months ago, and I heard of one of the actually a trauma surgeon, and she actually put a plug. Some type of a plug is available for a small esophageal injury like this. And she was successful in getting that esophageal injury healed. I don't know how it is done, and I kind of lost interest after I read about it, and I need to pursue that a little bit further to see exactly what did she do. But there are endoscopic techniques available. You don't have to open the patient up because this is a small tear in the esophagus, and as long as the edges look all right and there's not a big hole, you can resort to using either minimal invasive surgery or endoscopy or something. Some people even suture this area, and there are surgeons who are very skilled in doing that. But I think I would just put a stent across this area or use the plug if the plug is available and if I know how to do that. Regarding the bronchial injury, there is no two ways about it. I think you need to do a thoracotomy to fix this. And in fixing that, you may have to do a lobectomy or something. How far is it from the carina?
We measured it at starting at about 1 to 2 centimeters from the carina.
Oh,
And
that makes it really difficult. Then you're thinking about a lobectomy or something, massive surgery. Well, I think I would resort to getting advice from the pundits and the professors and see what they would do, and call St. Louis. There's a fellow called Joel Cooper, who is a lung transplant surgeon. And you have lung transplant surgeon as well now. So I think I would ask for their advice. Thank you.
Thank you, Dr. Cassin. Dr. Collet, would you like to make any comment?
Just a minute. Okay, I agree with the comments. I think the first comment that I made, I think these patients can be treated the esophageal hole by endoscopy if you have equipment to do this, and the bronchus. Depends on the size of the hole and the fistula, if it's present or not. If there is no fistula or fistula is small, you can wait. Or if you can sometimes don't have, you can go to a thoracotomy and then try to fix it. It's very difficult sometimes to fix this fistula. And the result is usually maybe some difficult because you have some burn injuries of the bronchus because the ballot and the trajectory of the ballot. I think depends on that the size of the bronchus and what you do. You can put a stent in the bronchus too. If you have some stents, you can put a stent and close the hole in the bronchus. So I think this is another possibility to do with endoscopy and bronchoscopy. Using for thoracoscopy to try to fix the esophagus is one possibility. But when you have injuries with bronchus and esophagus, may be very difficult to do this using thoracoscopy. So I think in these situations, I think I try to fix it endoscopic and bronchoscopic. That's it.
Thank you, Dr. Collet. Dr. Menegoso, any comment?
Yeah, I agree with what Dr. Collet just said. I think that in this situation, especially if the patient is not doing so well, I think I would favor to ask for some help from endoscopy and bronchoscopy, maybe try to fix these injuries, at least try to minimize their clinical repercussion by really minimally invasive procedures. And I will only favor more invasive procedures if they weren't so well and they didn't succeed as well.
Thank you, Dr. Menegoso. Any other panelists would you like to make any comment? Thank you. Dr. Carter, your turn.
Thank you. This is a fascinating discussion. So we did in fact engage our lung transplant thoracic surgery group. We did discuss the use of endoscopy, interventional endoscopy, or even deploying a stent across the esophageal injury. We ultimately decided not to pursue that. We felt that we had a likely through and through esophageal injury based on the trajectory and the imaging, and that we were still well within, well under 24 hours from the time of injury. The patient was reasonably stable at this point with basically normal hemodynamics and no additional blood loss. And so the recommendation of the transplant surgery group in consultation with Dr. Martos was to proceed with thoracotomy. So for the next question, I'm just going to stipulate that we're planning for access to this mid-esophageal injury and a left mainstem bronchial injury. We're planning a right posterolateral thoracotomy. And our next question in discussing with the anesthesiologist was, how could we maintain adequate intraoperative oxygenation and ventilation with these two injuries and the need for access to the right chest?
Thank you, Dr. Carter. Dr. Kassim, would you like to make any comment?
I think you need to have this planned out with your anesthesiologist, and hoping your anesthesiologist is well versed in column tube and double lung, double tube, so you can deflate one or the other, definitely not both. And whenever that you think it is deemed necessary to get the lung down so that you can clearly see everything you want to see. So I think somebody who is well versed in colon tube intubation and management of the airway is very paramount. Thank you.
Thank you, Dr. Cassim. Dr. Frisbee, would you do something different?
No, a double lumen tube is what every anesthesiologist is gonna put down there. They're pretty well versed in all of this, but I would really talk to them prior to hitting the OR door with it, so that they would understand that there's going to be the need, maybe the need to drop one of the lungs, and but that's the only comment I have.
Thank you, Dr. Frisbee. Dr. Collet, any comment?
That you can make a selective intubation for the double endo tube, and can try to ventilation one the lung and all of the lung. So there is a problem when you put this in this patient, because you have an injury of the bronchus, and this can be enlarged the bronchus. So the with and very careful put this tube. And ventilation, the patient can not. Sometimes I have make operations with a thoracotomy with only endotracheal tube, and I compress during the surgery with the lung and can be approached the esophagus. And sometimes you can use the ventilation during the surgery. You can compress the lung. You have time to do the surgery to find the injuries, and then you can ventilation again, and then you stop ventilation and go and try to finish the surgery. So I think it's another possibility. The great problem is when you open the mediastinum, you can have the bronchus pleural fistula can enhance, sometimes may be difficult to ventilation the patient. That's the only problem. I think the first approach in this patient, you can go to the bronchus and try to fix the fistula, and then you can go to esophagus.
Thank you, Dr. Collet. Dr. Menegoso, any comments?
Yeah, I agree with the double lumen tube also. I'm going to be a little controversial here. I mean, a little, not a little, a very, very controversial, but I think that in very strict situations and also strict places, such as a Rider Trauma Center, for example, I think that I don't know if I have no experience with this, but I'm thinking that if you could not use, for example, an ECMO machine to make sure that you're having the right oxygenation all the time during the procedure because of the fistula, I think that it's quite difficult and maybe it's a little bit risky to put the double lumen tube inside the bronchial injury, considering that it's 2 centimeters from the carina. So I think that I have no experience with those, and I don't know how aggressive that would be. But I think that it would be a situation where you could work in both lungs if necessary, and you won't have any problems with the double lumen tube.
Thank you, Dr. Menegoso. Dr. Carter, your turn, please.
Yes, thank you. So that last response is exactly what our most senior anesthesiologist told us about the dangers of placing a double lumen tube in this patient. So that left mainstem bronchial injury, being as proximal as it was, really made them quite nervous to attempt single lung ventilation to the left side so that we could drop the right lung and work in our surgical field. So in fact, we did activate our ECMO team and brought them to the OR and decided to proceed with cannulation for veno-venous ECMO. We used a right internal jugular 18 French cannula and a left femoral 23 French cannula, confirmed with fluoroscopy. And once those were positioned and we went on circuit, we were able to essentially cease ventilation with our mechanical ventilator and the patient maintained excellent saturations and clearance of CO2. We repositioned the patient with cannulas in place so that the right side was up in a lateral recumbent position. And then prepped and draped in the standard fashion. The patient received preoperative antibiotics with Zosyn and fluconazole given the foregut injury. And then we proceeded with right posterolateral thoracotomy with access in the 5th intercostal space. We harvested an intercostal muscle flap on the way in, took down the inferior pulmonary ligament, and identified a small hole in the posterior mediastinal pleura, which seemed to be the trajectory of the ballistic seen in the right upper lung. This hole was within millimeters of the azygos vein. The azygos seemed to be uninjured, but for improved visualization, the azygos was taken down with those silk sutures and vascular clips. And from here, we could carry our dissection into the subcarinal space and encircle the distal trachea as well as the right and left main stem bronchi. So here is our dissection, and I'm just going to play a video identifying the structures here.
This is inside, right? You can see the light. This is the light on the bronchus. You have the right main bronchus, trachea, left main bronchus in circle. We have the esophagus here, which has the hole through and through. We have muscle flap here on the leaf. Not only that, you can see the esophagus. You can see it, I can see now. And that's the low, that's the locus structure there. And it starts here.
So, I actually want to let this keep running. So in the current exposure, you still can't see the left main stem bronchial injury, and they're about to show how much is required to expose this.
Just lift here, please. Oh, yeah. Section. Yeah. All the way down. Like this. And keep sucking. Yeah. Very peaceful, but
Okay. So they're just in the sort of distant left side of the mediastinum, just at the far extent of our dissection. There's a linear, perhaps centimeter long injury to the membranous wall of the mainstem bronchus. This was repaired with interrupted sutures of 4-PDS, and then saline leak test was performed, which demonstrated no air leak. For our esophageal repair, there was in fact a through and through injury. The right-sided esophageal injury was relatively straightforward to identify. The injury to the left lateral wall of the esophagus was pretty challenging. And in fact, we had to find it first using intraop esophagoscopy, and then ultimately get an instrument across both injuries and pass the blue vessel loop, which then traversed both the left and right-sided esophageal injuries. So in these pictures, the blue vessel loop is positioned across both injuries, and a penrose is encircling the esophagus posteriorly. Even with this dissection, we really could not visualize the left-sided injury adequately to perform a safe repair. We knew that we would need to extend the muscularis injury on the right in order to visualize the mucosa and do a good mucosa to mucosa repair. And once we started extending the muscularis defect, we found that just extending by perhaps a centimeter or so allowed us to visualize the left-sided esophageal injury from the inside of the esophagus. We then placed 4-PDS stay sutures to maintain this visualization. On the left-sided injury, there was some non-viable tissue that we debrided. And once we were back to healthy appearing mucosa, we repaired the injury in one layer from inside with interrupted 4-PDS. Then under direct visualization through the right-sided injury, we passed the nasogastric tube for gastric decompression, as well as a Daboff nasogastric feeding tube for enteral feeding access. And then once those were secured, we repaired the right esophageal mucosa with simple interrupted 4-PDS sutures, followed by a muscularis layer with horizontal mattress interrupted 4-PDS. Once our esophageal repair was complete, you see that image on the left. We then positioned the intercostal muscle flap between the esophageal and the bronchial injuries, and in a position where it buttressed both repairs, and it was secured in place using 4 interrupted 2 ovicral sutures. An additional very much appreciated contribution of the lung transplant surgery team was the use of cryoanalgesia to allow durable pain control without having to use a thoracic epidural, other neuraxial procedural analgesia. So they use this technology in many of their patients, and they introduced it to us. And so we did cryoanalgesia of the intercostal spaces from the 3rd to the 7th. We placed 2 28 French chest tubes, one directly above the diaphragm and the other apically. And then we placed an additional 2 10 French Jackson Pratt drains, one at the site of the bronchial injury anterior to the intercostal muscle flap, or running along the flap, and then another one at the esophageal repair posterior to the flap. Here's our post-op x-ray with drains in place. And an immediate post-operative bronchoscopy showed no narrowing of the left main stem bronchus and an intact repair. In the post-operative course, one of the benefits of being on VV ECMO was we were able to stay on circuit and pretty much immediately extubate the patient the following morning to take him off of positive pressure ventilation and allow that airway injury the best chance to heal without additional barotrauma. I wish I could say we had a totally complication-free course, but unfortunately, the patient turned out to have what seems to have been a missed injury in the splenic flexion of the colon, either not seen at the prior laparotomy or perhaps a thermal injury from dissection. But at any rate, the patient developed free air a few days after his thoracic surgery and was taken back to the operating room, re-explored, had a segmental colectomy performed and a transverse colostomy. After that, he's done much better. He had a left-sided pigtail placed in a fluid collection within the pleural space, but that has remained sanguinous in its output. We started feeding the stomach using our Daboff access, and the patient is tolerating tube feeds that are now at goal. And as of this morning, he's been decannulated from his ECMO, and he's on room air, breathing pretty comfortably, and for now looking well. With regards to our repair, we got a post-op day 12 fluoroscopic upper GI, which demonstrated it was essentially interpreted as equivocal, possible small leak here on the left side of the esophagus. And so we followed that study up with immediate post-fluoro CT, and that also was concerning, though perhaps not definitively diagnostic, for a small contained left-sided esophageal leak. And so as of this morning, we are letting the patient take a PO challenge with actually with dark Gatorade. And if he tolerates that, we're going to start letting him take PO. So thank you very much again for the opportunity to present in this forum, and I'm happy to address any additional questions.
Thank you, Dr. Carter. We have a question in the chat. Dr. Italo Massini, did you use standard anticoagulation for VV ECMO in this surgery?
Yes, good question. We gave a bolus of 5,000 of IV heparin prior to cannulation, yes.
Thank you. Dr. Kassim, would you like to make the final comment?
This is the beauty of this trauma course put on by Dr. Matos, that you learn a lot. And that's a fabulous management of a very, very complicated case. And I must congratulate you, Dr. Carter, and your team and the lung transplant surgeon for coming up with the possible solution for others to learn how to manage a complex injury like this. Thank you so much for educating me today. I really enjoyed your presentation.
Thank you. It's certainly the team.
Thank you.
So we share the CMA code on chat. Can you please take note? So Dr. Frisbee, do you have any final comment, please?
Well, my good friend, Dr. Kassim, has all the words. I don't usually wax eloquent, but I'd be very interested in the cryo-anesthetic portion of this. You know, I'm not familiar with that. Is that simply relegated to the ribs and the chest cavity?
Yes, that was the access. I mean, it seemed amazingly simple to apply. You already have the access for your thoracotomy, and so you basically apply it to the intercostal nerve bundles on your way out from performing the thoracotomy. It certainly seemed vastly preferable to a thoracic epidural, and all the frustrations that can come with those devices, as helpful as they are in this patient population.
How the patient tolerate?
He tolerated fantastic. I mean, he tolerated extubation on day one, and really has not. He's had a lot of other problems, but pain from his thoracotomy has been very limited. And we're a couple weeks out now, but even this morning, he seemed to have near total control of his thoracotomy pain, which is really amazing. So
that is really, really nice. Thank you very much. A very good case.
Thank you, sir.
Thank you, Dr. Fritz. Dr. Collet, any comment?
Only congratulations for the case. Very interesting case. I hope all servers can have ECMO to use in these situations, but it's not fortunately to do for other countries or other places. So sometimes it's very interesting this approach. Congratulations for the approach. I hope I have sometimes ECMO here for using in this kind of case. Thank you very much.
Thank you, Dr. Collet. Dr. Menegoso, any final comment?
So I just wanted to congratulate Dr. Carter and Dr. Martos. Excellent case, very, very nicely done, and also well documented. It's quite difficult to do in such situations. And I found it really, really clever, the idea of using ECMO in this situation, because it's a really it's a very, very specific combination of injuries that may give you a very difficult situation when treating it without the ECMO. I think it was a very nice idea. Thank you very much for presenting, and congratulations.
Thank you, Dr. Menegoso. Thank you, Dr. Carter, for accepting our invitation, for the excellent presentation, for the excellent case. I hope to see you with us with more presentations.
Okay.
Excellent like this.
Nicely done.
Everyone check the code. Yes, please check the code, the CMA code.